My name is Kanu Chatterjee. I'm a clinical professor of medicine, the Carver College of Medicine, University of Iowa, and emeritus professor of medicine, University of California, San Francisco. I am giving a talk in the International Congress today about differences between systolic and diastolic heart failure. This is a very important topic because, as you probably know, heart failure is the most common clinical syndrome and most expensive clinical entity in cardiology today. We have a lot of treatment available for systolic heart failure. Unfortunately, we do not have any good treatment for diastolic heart failure. Now, so we need to know what is the definition of systolic heart failure and diastolic heart failure. The definition is fairly simple. When left ventricular ejection fraction is reduced, that is 40% or lower, that is defined as systolic heart failure. And when the ejection fraction is 45% or higher, that is defined as diastolic heart failure. There are fundamental differences in morphology and function in systolic and diastolic heart failure. For example, systolic heart failure, the ventricle is dilated, there is diffuse fibrosis, and there is increase in end-systolic and end-diastolic volume. Whereas in diastolic heart failure, the ventricle is stiff, ventricle does not dilate, there is a lot of fibrosis, and there is virtually no change in ventricular volume. In fact, the end-systolic volume may be reduced in some patients. There are other differences also in terms of pathophysiology. For example, there is marked necrosis and apoptosis in both systolic and diastolic heart failure, but necrosis is much more pronounced in systolic heart failure. Then, of course, it is of interest that there is no differences in the neurohormonal profile in systolic and diastolic heart failure. That raises a very important issue. We now know the treatments that have been shown to benefit patients with systolic heart failure are based on these neurohormonal changes. For example, the beta blocker, angiotensin converting enzyme inhibitors or aldosterone antagonists, all these are very important therapy which have been shown to improve prognosis of patients with systolic heart failure. Unfortunately, these therapies are not beneficial or has not been shown to be any benefit in diastolic heart failure. So the question is, if the neurohormonal profile is the same, why does the heart respond differently? So we need to do a lot more work to understand the mechanisms of these differences in systolic and diastolic heart failure so that we can actually get better treatment. And that has to be based on a better understanding of the pathophysiology.